Okay. Well, first of all, thanks again for joining us today. We're going to talk a little bit about how we combine movement and voice and cognitive components all into the same exercise. And rather than talking about this, we're going to just maybe show you what we're going to get into here. If anyone wants to join in, basically, whenever you see or hear the number 5, you're going to bring both hands up as you see us doing here. Okay. 5, 9, 8, 7, 3, 5, 6, 5, 7, 9, 5, What's happening here? Was that it? Okay. I don't know why. Okay, so as we go through the slides today, we're going to talk a little bit about why dual task exercise is important for Parkinson's, what it can look like at different stages of Parkinson's, maybe when we use it in the clinic versus whether we use it in gym, and then what resources you might be able to make available during COVID. Yeah, I'm just trying to, my own, all the view up here, I'm going to make it a little bit smaller, is actually hiding my ability to see it. There we go. Okay, well, so dual task capacity is probably formally defined as the ability to perform 2 tasks simultaneously. So one being primary and the other secondary, and they should be able to be performed independently. They should be able to be measured separately, and they should have distinct goals. Okay. So as you're going through that, you might watch something like this and you see a guy and he's texting or interacting with the phone while he's walking. Is that a dual task that we think? Yeah, that fits that guideline, don't you think? What if he was just walking and maybe talking on the phone? I'll say as a speech therapist or speech language pathologist that, yeah, that's probably a dual task. But what if they were just walking and holding the phone in their hand? And that might get a little fuzzier, right? Is that a second task that might be separately done or separately performed and measured? It gets a little foggier, but as you'll see with Parkinson's, because the parts of the brain that are controlling movement in the basal ganglia are impaired or impacted by the disease, that simply just holding the phone while you're walking or standing might actually have an influence. And Josefa will have some nice videos to show that a little bit later on. Now, dual task interference is a very important problem in many neurological diseases as well as in healthy aging, and that's mainly because it's a part of daily life, whether you're, looking on the phone or talking on the phone while you're deciding whether you're going to cross the street, or maybe you're trying to manage a conversation with a bunch of different things going on around you. It's a dual task. It's kind of a way of life. And then there's all the new life skills like, taking a picture while you're walking or live streaming or other 2021 life skills that I don't think most of us need to worry about, but I see that happening all the time. So when you start talking about speech and dual task, we're pretty familiar that there are issues with movement that show up. And you can see it pretty early on. Sometimes you can see it before other issues crop up. And I'll just say that it is the same for speech. It's a little harder to perceive sometimes if we're usually compensating. But if you're doing a dual task activity, you're going to see changes in the volume. Most people with Parkinson's end up having lower volume. The volume goes down quite a bit. You also find that the rate of speech may slow down a little bit. You have more pauses and hesitations and difficulty with initiation and word finding and that kind of stuff. And then the reaction time, if they're reacting to a stimuli. I don't like to usually go too far down a research rabbit hole for a conversation like this, but just to kind of highlight that, there was a nice study a couple of years ago, well, 12 years ago, a while back, and it had 15 people with Parkinson's and 15 people that were the healthy controls, people that didn't have a diagnosis. And they were doing this activity where they were doing spontaneous speech, and then they had a digit span kind of activity, a digit memory activity where they were responding. and they had to use this joystick and respond to stuff on the screen. And sure enough, the people with Parkinson's showed very significant differences in volume, in rate, in accuracy of the words they were choosing and the way they were articulating it. And that's not that unusual. I mean, I'm saying it with a research background, but it's fairly intuitive that if you're trying to do two things at once, if you're, loading the dishes and talking on the phone, you might run into that issue. But sometimes we do also notice in the gym environment that our folks will start to game the system a little bit. So Josefa will have an exercise and they'll fit it in between it. So they're doing activity and then they rush the response, the verbal response out there. And that's pretty normal. So you can do it that way too sometimes, where you have little rushes of speech that are interspersed very quickly rather than actually being slower like you see in the research, which is kind of the way a lot of research is. It doesn't always apply to what you see in real life. Now, if having this kind of conversation dual task is difficult, mealtime situations for dual task can be even more complicated, especially as you are getting into a meal environment and you have a lot of noise and maybe there's a lot of movement around and people are trying to converse with you and you're trying to manage this while increasing the volume and using all the great sound that your speech therapist has talked to you about and worked on you with you in LSVT or Speak Out. And then you're also trying not to have a choking incident or a coughing incident or some of the other issues. And so these are environments that are often fraught with a lot of danger, and it makes people not want to necessarily get out and engage in them because it can be so, I won't say traumatizing, just anxiety producing, and early on you might notice that you're having more difficulty in these noisier environments and they find them a little overwhelming. But later on, you might even find situations where you're going to defer or try not to communicate as much because you're worried about, just being able to communicate while you're eating the food and not choking and not having a coughing incident or spitting food out or something like that. So those are the big contexts where I think when you talk about dual task, speech and anything is probably the original dual task.
Which connects really wisely to walking. So hi, everyone. I hope my accent is okay for everyone. A little bit heavier. But so when we think about walking and dual task, so this doing two things at once, when we're walking and these difficulties are already seen at diagnosis and will progress throughout the disease, unfortunately. In early stages of the disease, people don't really report difficulty walking and talking, for example. But what we see is that they are not perceiving actually the difficulty. They are not aware that a leg is starting to drag or the arms are not balancing or not swinging as they are walking and talking with someone. There can also be sometimes, trips and stumbles, but people often relate these to environmental hazards or to footwear that is poor or imperfections that are in the pavement, or also very common, a previous injury that is causing that. So usually it will be more often that a family member who will be able to identify these activities of dual task. And they might share things like, oh, he seems to lower his cup and almost spills the coffee when he's speaking to me, or he has to stop walking while he's talking and carrying a cup of water. So these are nice examples of dual task. Then if something specific to that person, so it's like, imagine the person is dealing with postural problems. And so that means that when he's standing position and he's talking with someone, his posture will become worse. Or you have complaints of his tremor or his involuntary movements. Dyskinesia gets worse as he's talking with someone in the standing position. So of course, I'm noticing how I keep saying that the complaints are coming from the women, right? So it's just I wouldn't say they're more nagging. It's just women are naturally more attentive to these things. But objectively, we do have a considerable amount of research, showing that walking while you're doing an additional task can really reduce your speed. So it will slow you down. It can reduce the length of your steps. And it will also increase the variability or the changes in your walking pattern. So let's see this in this video. I think a video is always good to be able to see these changes. So I think the videos are actually coming out slow, but that's actually a good thing. So we can really see the changes. So you can see this is a gentleman that is in therapy. He has Parkinson for about 10 years. He's walking normally, but then I have challenged him to do a verbal and a thinking activity, which has really challenged him to the point that he starts really slowing down. You can see his arms stopped swinging as he was so fluently in the beginning. You can see also a lot of rigidity on his left side kicking in. He almost stops every time he's trying to think of the answer that I'm asking him. So what is happening here is the person is prioritizing so much the cognitive challenge that he is unaware of the motor changes that are occurring. To the point that I'm noticing how this is becoming really severe, and I'm telling him, I just want you to walk. I just want you to walk. And he is unable to even hear me. So he's so blocked in that thought that he can't even hear any stimulus from the outside. So I actually had to go by him and say, let's just walk, so that we could get out of that status. Now, when a healthy adult performs such a task, the quality of the task will also, decline. So people also slow down, but their walking pattern and their stability, their balance don't. So this is actually a normal strategy so that people would avoid falling as we get older. But in people with Parkinson, the opposite is happening. So the person is really giving a prioritization to the cognitive task first, with negative consequences over the walking, as you just saw, right? So the bottom line is, as the disease is progressing, you might see this slowness coming in, and you see more hesitation starting to happen. And people feel the need to temporarily stop to be able to actually engage in a conversation, especially if it's something that's really emotional. Additionally, we might have those episodes of freezing of gait, so the feet have the sensation that the feet are stuck to the floor. And this can primarily happen first in the turning position. As people are turning, imagine in the kitchen, you're cooking and you're going to turn, and then the foot seems to get stuck. Or when we're walking forward later, if you're crossing a doorway or engaging in a conversation, or I think the most important one is really making quick decisions. So you can have examples like the person is walking in the street and people are coming in their direction, and you have to make a decision. Now, this is normally done very automatic. You don't really think about it. And now it's a source of stress. I've had many people with Parkinson that come to me and say, I'm really stressed in the street because I don't know where to go. My natural response is, don't worry about it, because the others do. So if you really don't think about it, the person that's coming in your direction will take that decision, right? It's a strategy that hasn't failed me yet. So it's just analyzing the problem from a different point of view, I would say. So as you can see, all these changes eventually lead to balance difficulties, and of course, the increased risk of falls. And this is why this topic is so important. That's why there's so much attention being given to this. Now, interestingly, nearly all the studies and research that has been done for dual task performance in Parkinson, they usually use walking or balance activities, and then they add in some cognitive or additional challenges, right? And these are activities where Parkinson is particularly, I would say, have difficulties, right? So there was, when I saw the study, I found it interesting that there was a study that actually showed that a group of people, it was about 28 people with Parkinson, and they had a group control as well with people without Parkinson. And they had them do some exercise inside a pool, cycling, which is not really difficult to do. And adding in these cognitive tasks, what they were able to show in this program is that if these cognitive challenges are done in activities in which people with Parkinson are not impaired, then people with Parkinson will have the similar difficulties on the cognitive challenges. Now, this is very interesting information for us to understand, that maybe we don't have to be worried this is so severe in Parkinson. It's really imbalance issues that will highlight these difficulties, okay? So we did want to have here an example of the balance. And I think particularly in balance, that's where it's difficult for people to see this challenge. So we wanted to show you a video. Here is Barbara. She's 68 years old. And I think is a nice example of you to see how difficult it is to perceive it.
Yeah, I could be standing still and all of a sudden I just lose my balance. I can usually catch myself. I never usually fall. I can't remember an incident where I fell, but I lose my balance. I have to, like, it's real noticeable.
So you would say that you lose your balance backwards, like taking a few steps backwards?
Yeah.
So when you say I catch myself, you take a few steps and you regain balance again.
Yes,
right?
yes.
Okay. And this never happens forward, it's always backwards.
It seems like it is backwards.
Mm-hmm.
Yeah.
Can you recall a situation where this happens, and if you associate it to the fact that maybe someone is talking to you or you're doing an additional task?
No. I could be standing around listening to somebody, and I would lose my balance.
So someone talking to you and you're listening actively to them, right?
Yeah.
So that is considered doing something else. So it's like your attention is focusing on what that person is saying, and that on its own is studied to influence balance.
Okay.
So if you're listening to someone, if you are talking, do you think the same thing happens?
Yes, definitely.
It might be hard to distinguish, more difficult.
Probably talking, if I'm talking to somebody, although I'm a really good listener. I do better listening than coming up with words for people.
High five to that. I'm a good listener too, I think. Okay, so a very similar episode just happened this morning that one of the people that I'm following told me. It's like he was peeling peanuts. We do that in Portugal. So I don't know if it's an American thing, but he said he was so focused on doing that, his wife asked him something, and probably as he looked up, he lost his balance. So he started walking and he almost fell. So I think it's a very common situation that we don't relate to dual tasking, and that you might identify situations that happen with you. Now, this type of information is very interesting in many times in the clinic. If I'm asking someone some information, and so I know that person has balance issues, I will make a point of asking him in a sitting position, and I know that it will be easy for the person to answer me. Now, on the other hand, for example, if I have someone that's suffering from sleepiness, daily sleepiness, I will probably ask the question in a standing position, as I know that will facilitate him to be able to answer. So I think it's this type of information really helps us help people have a more successful experience every time they are in the clinic. So what about daily activities? In daily activities, I think the main complaint is usually people are telling me how they feel slow in the activities. They become more and more progressively slower in the activity. They're taking too much time, double the time, getting out of a chair, falling into the chair, getting out of bed. And all these activities are particularly worse under distracting factors. And you might see changes in speed, changes in the posture, losing the balance during these activities. What you see here in the video is a gentleman that is struggling to get out of the chair, and he almost falls as he turns. So he's 86 years old, and he's had Parkinson for about, I think, 5 years. And what is happening here is that automatic response, of balance, of postural control, required for him to remember that he has to pivot his foot first, so this would be an automatic response, has been lost. And so he will require some cognitive attention every time he's getting out of the chair. So now it's any action that precedes him getting up clearly will influence his performance and puts him at risk. So getting up to answer a phone or to answer the door. And in this case, I actually got this video because I was coming in and I knew this was going to happen. So I'm filming as I'm coming in and saying, "Hi, how are you?" and he's focusing on saying hi to me, and this happens. So I think it's also a good example of how people might not perceive these risks just because the cognitive attention is needed to control these type of activities now. So if we...
Am I ahead of you? I'm sorry, Jay.
No, it's fine. Next, yeah.
Well, yeah, and it's just, what are the solutions that we have for this problem? I mean, we have an increasing body of research that shows that, certainly non-pharmacological interventions such as physical training and cognitive training have shown some benefit for people with Parkinson's for both physical and cognitive outcomes. Our question or our premise is that we believe that putting the two of them together is a new method of treatment that may have more benefits. And despite a growing body of preliminary evidence to support the value of this kind of motor movement cognitive approach for Parkinson's, there are still a lot of difficulties revolving around how to apply it. How do we make sure that healthcare professionals who often struggle with accessing the professional knowledge, the expert knowledge on how to do it, when to do it, to whom to apply it, and for how to maybe modify that for different stages of the disease. If I can get there, beg your pardon here. Now, there is an optimal level of disease-specific expertise. The Dutch have outlined this in the past, but specific to integrating dual task practice, I think it's really how do you safely integrate it without putting people at risk for falls and other possible adverse interventions. If you prematurely apply this without that expertise and to people that with Parkinson's, whether you're a healthcare provider or an exercise professional, if you don't have the expertise, you may actually increase the risk of falls and adverse events. You could do something that's unnecessary, spend money on something that doesn't need to be done. Basically, you could include people with Parkinson's that have less potential for benefit, less favorable profiles or more risk. And you can really start to see how this might lead to some unrealistic expectations if you're applying it very widely. So all in all, you can see how this was going to have less confidence and maybe give you less long-term benefits because people may not adhere it because they're not sure that they're getting the benefit or they're not seeing the benefit. Generally, when we're doing this kind of work, we're hoping the proof is in the pudding pretty quickly, and it's not a keep plugging away at this and hopefully you'll see the benefits. It should be a little more straightforward.
So why we're talking about it now, I think is a good question to also try to answer. And it's not just because Angie asked us. No, it's specifically in the last, maybe I would say maybe 20, 30 years, there is a considerable amount of research that's showing the effects of cognition over movement and also vice versa. So I think it's the information that we can't ignore anymore and to which we need solutions. Then another phenomena is that it's actually spreading throughout the world. So I think most of you probably would have already had the experience of doing this in the gym or in the clinic, right? And I'd say boxing is probably a good example of how you combine the movement with the cognition. I would imagine most of you do it because it's very popular in the States. The amounts, I think I would say, another good reason, and any clinicians and the healthcare professionals and exercise try to guide themselves by the evidence that's coming out. And it's good to see how the evidence has grown and is catching up. And so there is a lot, an amount of published evidence already. There were concerns initially about, should people be avoiding this type of practice? Maybe we should be teaching people not to walk and carry things. And this initially was actually practice that we would do as physiotherapists. But in 2008, we had the first pilot study coming out from Australia, really showing the feasibility and the benefits of doing this type of practice. So it was later in 2014, I like to share that really it was 21 countries came together to publish the European Physiotherapy Guidelines, which is a very thick document of 200 pages. And we had to really decide about clear recommendations about to integrate this type of practice, because again, as I said, we cannot ignore the information that was coming out. So these, and I do want to highlight, so there was 2 studies that actually come, that are worth mentioning in this area, but there's a lot coming out. One of them was from Sweden, which is a high balance program. And so this was a Swedish program focusing on balance and gait under dual task situations, also showing promising results. And then later we had the duality study also that was comparing different types of ways that we could actually apply this type of training. So should we apply motor and then cognitive, or should we combine them both, was the question of the study. So very interesting studies but as I said, there's a lot going out. And our point here is not to go diving deeper into the research, but actually what I do want to share with this slide is to let you know that is considerable amount of research that has been published, and also a lot of ongoing research regarding dual task in Parkinson, as this is going to be a key emerging area for sure in practice in the following years. So what can it look like, I think would be our next focus. And when we think about deciding whom or when we apply this type of practice is still based on our clinical judgment, because yes, I was saying we do have research, but we don't have enough yet. And so it's really coming down to clinicians' preferences and the people that they have in front of them. We do know from this duality study that I just referred to that we are guided to start as early as possible. So in the study, what they found is that people in early stages of the disease benefit the most from the combination of the two types of practice. So it was people that would have already some slow gait speed. So the speed would be slow when they're doing dual task, and also have good cognitive functioning. And these were the people that had most benefit. So if we see here in video 1, so I would say early stages, you can really, what type of practice would we be using? And so you can see it's a more expensive type of training, right? So basically I'm grabbing onto something that men in particular like a lot, which is football in my country. And getting the principles of, I really want people to open up. He does have a cognitive task to it. He's alternating between hitting the ball with the chest or grabbing the ball. And as he gets better at this, I add in a cognitive task to when you grab it, I want you to do A, B, C, or D, or when you hit it, I want you to say something else. So adding in the voice as well as a good way to add complexity. And you'll see this with different types of people. And I think that's one of the benefits, is really trying things out and seeing how it works. What you can see in our second video is actually here in the middle stages, we are focusing on problems that people might encounter, more like turning, being able to do safely transferring from one chair to the other. So we're grabbing onto that exercise, and what you see is there's four chairs. Each chair will have a specific movement and has associated to it a number. So as I call out number 4, the person will have to remember which was chair number 4, will have to go to the chair and remember which movement had to be done. So as you can see, it may sound simple to some of you, but of course what we have here particularly is someone that is suffering from freezing of gait, and so you can see there's some cueing on the floor where I'm guiding her on how to do it. And that is really my primary focus. I want her to be able to really divide her attention to when she's in standing position, what she has to be focusing on, in this case, the cueing on the floor. And then when she sits down, that's when I want her to think about the movement. So it's really about when to do what, and to be able to shift her attention from those activities. What we can see in video 3, so someone in later stages, what the research also gave us some information on this, which would be people maybe with greater disease severity are probably less likely to improve, but it is still feasible. So here we have a gentleman, he is 93. And our main goal is to be able to train sitting and standing so that he can do this safely, as he had a risk of falling associated to that. What happens is this gentleman comes in for twice a week therapy, and as an ongoing strategy. So you can imagine that there's only a certain amount of time that I can train sitting and standing, and we have to find more engaging ways to be able to do and keep the person motivated. And what he's doing, we can increase the complexity by the person having to memorize different letters on the wall. Like imagine the first time he goes, he has to remember 2. The second time he has to remember 3. Try to localize them and then touch them and get back to the chair again. So of course, this will increase according to the response that the person is giving. Now, in our next slide, I really want you to focus here on the image. Notice the gentleman in the photo. I guess we all would like to have, you know, these superpowers where you could do just so much at the same time, right? Women are particularly good at this, I think. We are well known for this, right? But this is not what we're talking about here in Parkinson. We're talking about situations that used to be automatic and now they're not, or they're having difficulties. And so now it became a dual task. So standing and talking with someone suddenly, because you have Parkinson, is now a dual task. So sometimes when I'm approaching people and you ask them, do you feel that you have difficulties with this? No, I don't. Why would I do it? Why would I do 2 or 3 things at the same time? It's not comfortable. It's not good. And so you're absolutely right. But now we are talking about specifically balanced situations and situations of posture that you can see in the photo, for example. So this is a woman with 15 years of Parkinson's disease. And I came in the room and I quietly took these pictures. And why quietly? As you can notice, where is she sitting? She is sitting so at the edge of the chair that is amazing how she did not fall. Luckily, I'm usually very calm when I come in the room, so I'm not. If I had shouted out her name or say good morning, I would have startled her and she might have fell. But even the chair here by the computer is amazing with the wheels. You can look at the picture and really become scared to look at these situations. But basically, it's just she's so focused on the task that she's doing, additionally, either on the phone or on the computer, that she's unaware that she's placing herself at risk. And this is why we want people to be able to take these decisions better. Okay, so what I wanted to share here is just show with you that I think most health professionals at this moment, we are struggling on how to do it because there's still no strict guidelines, because there's so many things that can be at play here. You know, the type of person we have, the time of the disease, the problems, the environment, that it really requires us to think a lot about how we're going to apply this in order for it to be comfortable. So I say this is just sharing with you the way I'm looking at it when I'm thinking of an activity. And first of all, it's like really defining what is the problem. So if we think about the video of the gentleman that was walking and talking, his main problem is he has to stop to be able to talk. So his wife is complaining that she doesn't really understand when they're walking and he's talking. The video was quite low, but he was really having difficulty with the talking, sorry. So that would be our focus. Is like, how can we help them reduce this problem? So if we think here on number 2, I'll be thinking, so what type of activity will I focus on? So they want to improve the capacity to walk. They want to improve the capacity to talk and walk. So as my secondary task, I'm going to be including progressively voice challenges, because that is our combination that we want to target. And then what happened in the video, as you can see, is like something started going wrong, right? So you have all these compensations that started happening. And so we as I would say health professionals really have to be able to identify these risks and these compensations, and then figure out, here that you see on 5 is like, figure out how are we going to reduce this. So how can I guarantee the quality of the movement before I try to add in more and more tasks, right? This is not like I'm going to explode the person by adding and adding. So it's like in that situation in particular, if he's slowing down, if his step size is becoming smaller, maybe I can consider having lines on the floor where I initially challenge him to be able to take that step size. And this is a good way for him. Or if I decide to do it on the treadmill, and I have lines on the treadmill, so I'm guaranteeing that he's always taking a nice step. And in that case, maybe I have his hands on the rail of the treadmill so that I won't have that compensation on the posture. So there's ways to bypass, and that's the message here. That in just reinforcing that we don't want to lose things that we've been working for in terms of goals of quality of movement by adding in these things. We need to find ways to be able to apply it safely and correctly. And this also brings on a key message, which is we have to learn also when to interrupt it. So you could see, it's like I show that video, but I'm actually, I'd say it's a negative video because we took that person to extreme, and that shouldn't be, that is not therapy, right? You can do that as an assessment, but what I must be able to is identify if this is happening, and before it happens, I must find ways to be able to distract the brain quickly so that he doesn't enter into frustration. And so sometimes, as Angie was saying, I share some videos, and the videos are a lot of, it seems like people are playing or something. We are actually distracting people from the stress that we just imposed, right? So there, I would say it's not rocket science, but it surely deserves people thinking about what are they really asking, people with Parkinson to do, and if it is comfortable. And I use this word as a key word. It has to be a practice where it's comfortable, it's enjoyable for the people, for the therapist, and for the person undertaking it. So I'd say as the years gone by, it's I naturally come into this practice because you just listen enough to people complaining about these difficulties that you understand that I can train a lot of sitting and standing, but if it doesn't transfer to the home setting, it really doesn't, it's not useful, right? So it's what's happening in the home. In the home, people are distracted by other factors, and this is what, so we have to, I would say the first reason that why I would use it is really to improve the dual task performance in real life. So these situations where the person identifies that he is not dealing with the interference and with the distracting factors. The second reason, I would say, definitely to increase the complexity of the training. So once your brain gets used to something, we have to challenge it more in order to get better results. The third reason I would say is, and they're all kind of like connected, because here I've increased the complexity, and then I want to keep the person also motivated. So enhancing overall motivation is also one of the key reasons why I would use it. And then specifically to enhance tolerance to practices that I call boring, right? So there's practices that we ask people to do and are quite tedious, and so this is a nice way for us to make it more tolerable by gamifying the exercises. And I would say the last one is ultimately what we are trying to do is to prevent or delay, the onset of these two dual task difficulties and impairments that people have. So shall we see an example for each one of them so it makes more sense? So I would say here we use it, as I said before, when there is a clear presence of a complaint of dual task impairment. So it's either verbalized by the person or by the family member. It is important for everyone to understand why we're doing this type of practice, right? Or nothing will change. And then here we want to objectively improve the patient's capacity to be able to dual task in that situation that he's doing. So this is just an example, again, our gentleman, where we are trying to, I would say, capacitate him to be able to deal better with those distracting factors of when he's getting up. Being able to really, I would say, make the person be aware that there is a risk, that he understands that having Parkinson will make him often choose the wrong task to focus on. I think that would be the primary goals here. So there's, I would say, minimum equipment required, right? So it's just a chair, a window, and I found his environment very interesting. So what I'm just challenging him to remember where I touched, and then be able to, as he get up, to do the sequence first forward and then backwards. And he's surprised how this is so difficult. Again, 86 years old, so we have to keep that in mind. And now the way the exercise is progressing is just challenge him to have more variations where he's transferring from one side to the other. And at the end, what I'm doing after I have challenged someone cognitively, I usually distract him with some physical exercise. So if you relax your brain by working your body, it's usually a rule of mine. Okay, so if we go to the next one, John, it's fine. Our second reason that we had, which was improving so our capacity to do tool tasks, but with more complexity, right? So this is someone that told me that many times he's at home, he has almost fell when he's going to sit down because he's distracted by what his wife is saying to him, or he's watching TV, and then he's just not analyzing well where he's going to sit. And so this was an exercise that we arranged so that I could, I would say, help him understand when to focus on what, right? So, and I think so. Only when this task of sitting down, and he understands that we have to be able to feel the chair behind us before we sit down, so those tricks that therapists automatically, teach people. And then we can just increase the complexity. So when he's throwing the ball against the wall, he has a distracting factor, a cognitive task associated to it. And we just want to, train him to prioritize the attention toward the right task at the right time. Then when we think about our third reason, which is to enhance motivation. And I would say, I'll just share with you that these are people that are coming in and they are doing therapy 2 or 3 times a week. So you can imagine if they're always doing the same thing, how I would say boring out that would be. So we have to find new ways to be able to keep people engaged. So I think this type of practice has helped me a lot throughout these years to be able to do this. And what we are seeing here is, it seems like a weird type of exercise, but we are using boxing because we all know how popular that is. And he has all these variations of the balls that he has to go through, and he has a specific task for every ball. So when he hits the ball on the right, he has to say a letter. When he hits the ball on the left, he has to say another letter of the alphabet. When he hits through, so there's a whole sequence that he has gradually learned. So it's not like I start at this moment in the exercise. We progressively go into it. Being that my ultimate goal here is to be able for him to turn safely, even under distractions. Comes back to balance and turning during balance. Balance during turning, sorry. So when we think about our fourth reason, and I would say definitely one that I like most. This is actually a video from many years ago, and it's balance training. Basically, the person is on a balance pad, and I'm asking him different things associated to the letters that are in front of him. I particularly think that balance training is often considered boring, and so to enhance the tolerance to this type of training, that is, as I said, quite tedious, unexciting in nature. So ultimately, if there is something specific, that the person is having trouble doing it, we are going to choose that type of training and then just increase these variables and cognitive loads. So he would have to be staying there, right, and repeating that. And by doing this activity, and the ball is actually a factor for him to be able to keep his posture upright, because as he's on the balance pad and he's answering me, his posture was getting worse and worse.
Oops, sorry about that.
It's okay. So I'd say we're missing one, and which is our final one, really to focus on to reduce, at least potentially reduce the delay or delay these dual task impairments, right? So this is definitely another reason to use it. We are receiving people earlier and earlier in terms of the disease, which means we have to focus on several prevention issues. Knowing that the underlying progression of the disease, we can really focus on choosing these activities accordingly, right? So additionally, progression involves impairments in learning as well and relearning skills. So making it more and more difficult in later stages for us to be able to use this type of practice. So the earlier we begin would really make, is going to give us more benefit for sure. So as we think of prevention, we will have to, decide on which tasks to focus on, and dual task training may be more important to certain tasks and to certain contexts as well. So as a baseline decision, I always use, the training that incorporates activities that the person will most likely encounter in real life, for that person.
So people often ask how they can find some of these activities. We've done a couple of different initiatives. This is one with Bial, which is a Portuguese pharmaceutical, and it's called Keep It On, Keep On Moving. And those are available for free on their YouTube channel. It's a nice, easy way to get to them. And you'll see a lot of the same activities that we would use in a clinic, and we're just making it more available to the wider population of people around the world. Apropos of nothing, that pharmaceutical, when it comes to the States, it's going to basically be a replacement for entacapone. It's going to be really interesting. So keep your eyes out for that company. And we started this actually with an initiative with the European Parkinson Disease Association, the EPDA, which is kind of a governing body for a lot of different entities in the EU. And we call it Exercise Cast, and it's the same situation. When the coronavirus situation happened, and we saw that a lot of people that we work with weren't going to be able to get into a clinic, we thought maybe we could do something to provide exercises for people around the world. And it was a lot of fun recording these. Again, it's been replaced by Keep On Moving, but this was where it all began. And again, these are also available for free. I'd say instead of going to the YouTube channel for the EPDA, which has thousands of videos, you might go actually to their website and look up their resources with Exercise Cast and find it directly that way. And then we also have our own website. We do our own work online, and it's dualtaskforparkinsons.com, and that's where you could do some one-on-one or small group. We do some group stuff that we're getting ready to start next month with a group out of Washington. And just another way to connect and do this. This actually used to be how we'd have people come over to fly over and work with us, but that's on hold for a while. It'll change soon.
Yeah, I think so. Our final message, I would say, this is a nice analogy that I like to think about dual task training as having like an experience of refereeing, like you navigating all these river of options and things changing all the time. You're going through sections and exercises that are more difficult and others that are less, dealing with some risk, but then all this has to be part of a nice, challenging, but also fun experience. So I think a key message is really, it has to, we have, as therapists and health professionals, have to find a way to make it more fun for you. And I think it's important for the people with Parkinson to understand that you are not supposed to leave a session where you feel frustrated. It's not positive for your brain, right? So just be mindful of that, and all feedback is always very important when you are doing this type of practice. I would say that if you see that video that I was saying that's negative, if that gentleman were to leave the session at that moment, I would imagine that he wouldn't come back. So it's vital for me to understand that happened, and then we have to quickly change the activity and do something fun. And at the end, everything was okay, and it's almost as if it didn't happen. So that was our key messages for you, and I hope it's useful.
I was looking in there. I'm going to stop the share. I was looking because I was thinking that was the picture. One of our good friends, Nancy Hilmer, who is an occupational therapist, her husband Tim led those, and I remember they had that great picture, and I've been looking for him in there. But this is a different.
Yeah. I looked at it and I said, I want to do that one day, but I'm scared.
I'm scared too. But yeah, maybe we can open it up to some questions if people have anything they wanted to ask about this.